So for well-differentiated neuroendocrine tumors, what we found is that response rate are quite low with immunotherapy. Definitely in the single digits. In fact, with midgut neuroendocrine tumors, the response rates are negligible. And these tumors are very rarely even intermediate mutation burden. They're almost always very low mutational burden. For poorly differentiated neuroendocrine carcinomas, the response rates have been a bit disappointing with single agent PD-1 or PD-L1 inhibitors, but there's conflicting data, I would say, on combinations of CTLA-4 and PD-1, such as ipi-nivo. With one study showing relatively high response rates in an unplanned subset analysis, and another study looking at meditremi showing fairly low response rates of about 10%. And in our experience, the response rates are probably around 15% or so. So, and then, with the drugs, of course, some people can achieve long-term remission. So the chances are low of seeing response, but occasionally you see a pretty dramatic, long-lasting response. And given the absence of good treatment options beyond first-line carboplatin for poorly differentiated neuroendocrine carcinomas, I'd say it's reasonable to try something like ipi-nivo. There's some controversy over whether you should add a PD-1 inhibitor in the first-line setting in poorly differentiated neuroendocrine cancers, as is done in small cell lung carcinoma, I should say. And that's because these tumors are similar, but not identical to small cell lung cancer. I could also say that occasionally well-differentiated tumors become aggressive over time. They accumulate mutations. And so in tumors that become quite aggressive over time, or in which there are not too many options, I think it's reasonable to try immunotherapy, and occasionally we'll see a response. But overall, immunotherapy has not had nearly as substantial a role as it does in many other cancers.